Good evening everyone, I'm Dr. Habib and today we'll be discussing hypercalcemia. This video is made for medical students, although foundation year doctors may find it useful. So to summarize, we will discuss calcium metabolism, etiology of hypercalcemia, clinical presentation, investigations, and finally the management. The most important hormone involved in calcium homeostasis is parathyroid hormone, and this is secreted by the parathyroid glands. Other organs include the GI tract, kidneys, bones, and the thyroid gland. The parafollicular C cells secrete calcitonin. Calcitonin is a hormone produced by the thyroid gland, and it serves to reduce serum calcium levels, thereby opposing the action of PTH. This is important to maintain bone health. Calcium is also involved in neuromuscular function and also helps in cell death, for example, in apoptosis. PTH causes increase of calcium levels by three mechanisms. It causes resorption of the bone, increases absorption in the small intestine, and reduces renal excretion of calcium. We'll also have a quick look at the synthesis of vitamin D in the next slide. So UV rays from the sun come into contact with the skin where they're absorbed, and the skin produces a compound called vitamin D3, also known as cholecalciferol. From here, it's metabolized in the liver to form 25-hydroxy vitamin D. This happens via a hydroxylation reaction, followed by a further hydroxylation reaction in the kidneys this time to form 1,2,5-dihydroxy vitamin D. Keep in mind that this is the active form of vitamin D, okay? From here on, it goes to the gut to cause absorption of calcium and also has other functions such as boosting immunity, okay? So this is a brief illustration of vitamin D synthesis. So what about the causes of hypercalcemia? It's good to classify them into different categories such as primary, neoplastic, inherited, drug-induced, endocrine, and even granulomatous causes such as sarcoid. Let's have a quick look at all of them in brief detail. So primary means when there is increased PTH levels in the blood. This can happen due to primary hyperparathyroidism as seen in hyperplasia of the gland, or more commonly adenoma of the parathyroid. It can also happen due to a carcinoma which is secreting PTH. Okay. Tertiary hyperparathyroidism happens in chronic kidney disease. Other causes are malignancy. Two mechanisms come into play in this category: a bony invasion by metastatic disease. It could be a lung cancer, breast, renal, or even thyroid. And the other mechanism is secretion of a PTH-related peptide, classically seen in solid tumors such as squamous cell carcinoma of the lung. Inherited causes: familial hypocalciuric hypercalcemia. This is autosomal dominant and usually asymptomatic. Usually a 24-hour urinary calcium is done to help in the diagnosis of this condition. Some drug-induced causes such as thiazide diuretics, vitamin D and A intoxication, sarcoidosis, and finally endocrine causes are rare, but they include high thyroid levels, acromegaly, Addison's disease. So what symptoms do patients present with? It's useful to again classify them into organ systems, such as the GI tract, renal, and the central nervous system, or quite a popular mnemonic: stones, bones, groans, thrones, and psychiatric overtones. Stones refers to renal stones, bones refers to bone pain, groans are abdominal symptoms, thrones refers to polydipsia, and psychiatric symptoms refers to any central nervous system involvement. Okay. So in this instance, when someone presents with polyuria and polydipsia, one of your other top differential diagnoses should be diabetes. So what investigations would you do in someone with high calcium levels? Well, serum calcium levels is the most obvious one. You can also request a bone profile. You can also get magnesium levels along with it. Bear in mind that this is a corrected calcium level, i.e. adjusted for albumin levels, as most of the calcium is bound to albumin. So if your patient is very malnourished and has low albumin levels, the best thing to do is request an ionized calcium, and this is usually available on a ABG sample. You can request some Usinese renal function tests, serum PTH levels. These can differentiate between primary causes versus neoplastic causes, PTH levels being undetectable when it comes to neoplastic disease. Okay. And in primary disease, it's going to be quite raised, as in with a parathyroid adenoma. A chest radiograph will help you exclude, say, hypercalcemia of malignancy seen in lung cancers. You can see a mass lesion. You can even see a pleural effusion. You can do a myeloma screen. Multiple myeloma also comes under the neoplastic category. It has high calcium levels and shows renal failure on the biochemistry. Vitamin D levels can also be useful if you suspect vitamin D intoxication, and a 24-hour urinary calcium can be used in cases of familial hypocalciuric hypercalcemia. In terms of the CT neck, ultrasound, and cystomebi, these are classically used to localize a parathyroid adenoma, and also because we're gearing up these patients for surgery. You wouldn't be expected to request these on your own as a junior doctor. This would be usually recommended by the thyroid surgeons or the endocrine specialists in the outpatient settings. Okay. We can also perform thyroid function tests, Sun-Eyck test to diagnose Addison's disease, and glucose tolerance tests for acromegaly. You can also do x-rays. For instance, you could see lytic bone lesions of the humerus. Renal ultrasound can show you renal calculi, and also a DEXA scan to check density of the bone. Okay, just bear in mind that the endocrine causes are infrequent and the most important causes to remember are primary and causes related to malignancy. And finally, looking at the treatment options. So if you're the junior doctor on the ward or in the accident and emergency department, or even in the acute medical unit, rehydration would be the first step in management. So you can give them intravenous 0.9% sodium chloride infusions, about 3 to 6 liters in the first 24 hours, and you can repeat the calcium levels thereafter to check for response. Failing this, the next appropriate drug of choice is bisphosphonates. So basically, bisphosphonates work by inhibiting the action of osteoclasts. Thereby, they reduce bony resorption and reducing serum calcium levels. An example is permethrinate, about 50 to 60 milligrams, diluted in 0.9% saline, and you can always adjust the dose based on the response. The third line in the management is calcitonin. Remember that the parafollicular C cells of the thyroid already secrete this hormone, which opposes the action of PTH. This can also be given for cases unresponsive to bisphosphonates. 100 units every 6 to 8 hours by either a subcut or intramuscular injection. And you can give the IV route, but this is only for emergency cases. By this point, you would have certainly had senior input from either the registrar or the consultants in treating hypercalcemia. And another treatment option is corticosteroids. This is predominantly for hypercalcemia of malignancy. You can try hydrocortisone 2 to 400 milligrams intravenously per day, and this can be continued for 3 to 5 days. So that concludes today's talk. I hope you found a value in this video. It's my first video on YouTube, and any comments, any questions about the content, any suggestions for future improvement are most welcome. I'd be most grateful if you could hit the like button and subscribe to my channel. And I'll make every effort to improve the subsequent lectures. And I'd like to thank you for your time, and I'll see you soon. Thank you. Bye-bye.